This program is brought to you by Emory University.
Hi, good morning, everyone. It is my pleasure to introduce one of our own, Dr. Kreton Mavromatis, who is an associate professor here at Emory and works primarily at the Atlanta VA. He's going to talk to us today about a very important topic that we all want to get up to speed on: ischemia after ischemia. Where do we go from here? Dr. Mavromatis went to medical school at University of Michigan and did his internal medicine training at University of Washington. Subsequently, his interventional cardiology fellowship here at Emory. He's been involved in many landmark trials and has been a PI on studies such as FAME2 at the VA and many others. His CV is so long that it will take us forever to talk about all the clinical trials he's contributed to. In the ischemia study, Emory was one of the highest enrollers, and so I'm really looking forward to getting his thoughts about what to do with ischemia. Dr. Mavromatis.
Thank you. Thank you, Pooja, very much. It's great to be here and talk about this trial, which has had so much hype around it for the last many years. This is a patient I saw the week after the ischemia trial results were released at the AHA this past November. He was a 62-year-old truck driver who was referred to cath after presenting with chest burning and walking up hills for the previous approximately 6 months. He had this exercise treadmill myocardial perfusion imaging study where he exercised 4 minutes and 45 seconds before stopping. He had ST depression and leads V4 through V6, and on imaging he had an inferior reversible defect, about 20%. He was started on aspirin at that time, and metoprolol and atorvastatin, and he was referred for cath, and he came in for his cath appointment, but he questioned its need. He said he'd been reading that prior week the newspapers, and I bet he was seeing headlines like this, ischemia-based headlines, which you probably have all seen. And you know, I don't know if any of you run into these patients, particularly the cath or interventional doctors watching us, but since ischemia was released, I've had many patients call in or come in questioning the need for revascularization based on all the publicity that the trial generated. For the rest of this talk, I would like to discuss the available ischemia data. A lot of it has been released in the meeting, and it's getting ready to be published, and I think the meeting is well representative of the data that we will see in the first set of publications. I'll talk a little bit about the primary conclusions of the study, and a little bit about my own additional observations. Others may have had the same. And finally, what I think some of the implications of this study might be. So the background behind ischemia is pretty straightforward, although revascularization by bypass has been shown to reduce mortality compared to medical therapy alone based on studies in the 1970s. Contemporary studies like these three, Courage in 2007, Berry 2D in 2009, and FAME2, have not shown any reduction in death and MI by revascularization compared to medical therapy. And this has led to a lot of criticism of the trials. The trials have been criticized for being very designed with a lot of selection bias in the population that was chosen, because patients who had mild or no ischemia were included, and patients were also randomized after angiography was performed, meaning that patients with some of the worst coronary anatomy may have not been included in this study. And the other criticism of this study is centered around the contemporaneous of the treatments. Mostly these studies were PCI, used for revascularization, and mostly the stents used were bare metal stents. And we're now up to second-generation drug-eluting stents, which have been shown to have better outcomes. So based on these criticisms, the ischemia trial was designed because many people did not adhere to the results of those previous 3 trials. This randomized controlled trial of invasive versus conservative therapy of stable coronary disease was really designed to address the limitations that I just mentioned. Number one, it was designed to reduce selection bias in the selection of subjects for the studies. Only moderate or greater ischemia patients were included. Number two, it was patients were to be randomized before a invasive coronary angiography. The second thing is that contemporary therapy was heavily encouraged to be used. Second-generation drug-eluting stents and FFR guidance for that stenting whenever necessary was strongly encouraged. And lastly, this study was designed to be twice as large as the most as any of the previous studies, increasing the power to detect potentially important differences in mortality. The eligibility criteria can be seen here, but in short, there was just about 4 or 5 critical inclusion and exclusion criteria. This one, patients had to have at least moderate ischemia. That meant on imaging, they had to have it, for example, on myocardial perfusion imaging, they had to have at least a 10% reversible defect, and there were similar moderate to, or greater ischemia criteria for DSE and MRI. Or they could be included if they had severe ischemia on exercise treadmill testing, which meant at least 2 millimeters of ST depression plus angina at less than 7 METs of exercise. Excluded were patients who were either CCS4 or recent onset CCS3, patients who had low EFs or NYHA 3 or 4 heart failure, and patients who had either left main disease or no obstructive disease, as noted on a blinded CCTA that was performed on most patients prior to their enrollment. Here you can see the study flow. 8,518 patients were enrolled. All of these patients basically had CCS2, angina, and moderate ischemia. Pretty simple. About 40%, 3,000 or so, were excluded though. They either had insufficient ischemia because the core lab was generally stricter than the local labs in terms of reading the amount of ischemia, or they had no obstructive disease or unprotected left main disease on blinded CCTA. The patients then randomized included 5,179 patients, and half, 2,500, were randomized to the invasive arm. These patients had to have cath within 30 days, cath and revascularization within 30 days. FFR was asked to be performed for anybody with less than an 80% stenosis that did not have associated non-invasive ischemia on prior testing. And full revascularization was encouraged for any vessel greater than 2.25 millimeters. In addition, these patients were placed on an OMT protocol, an optimal medical therapy protocol, which was basically following the ACC guidelines, plus study personnel were designated as case managers to help implement that protocol. Those randomized to the conservative arm were simply placed on the OMT protocol with case management and only had catheterization and revascularization if they had angina that was refractory to medications or they had actually an endpoint occur. Here you can see the baseline characteristics. The mean age, pretty standard for these kind of trials, 64 years of age. A lot of diabetics, probably higher than most coronary disease, stable coronary disease trials at 40%. Ejection fraction, as you might imagine, was fairly normal considering they excluded patients with heart failure. Most patients got into the study based on stress imaging testing with 75%. About 25% did get based on only on exercise treadmill testing, which showed severe ischemia. This is shows you how much ischemia the patients had. Basically, 87% either had moderate or severe ischemia. Some patients did slip in with mild or even no ischemia because the core lab wasn't quite able to adjudicate every stress test prior to the patient's randomization. So we do have a small contingent with mild and non-ischemia, but most had moderate or severe ischemia. Unbeknownst to the investigators, about 70, these are the coronary CCTA results that were not known to the investigators, but that 77% did have multivessel disease, with about half, 50% or so almost having actually 3-vessel disease by CCTA, and 46% actually had proximal LAD involvement by CCTA. So these are fairly high-risk patients. The patients in the invasive arm ended up undergoing their prescribed treatment by and large. 95% had heart catheterization and 80% actually had revascularization within the time limit. As you can see here, about 20% did not have any revascularization, probably because 2/3 of them had actually insignificant disease, and 1/3 of them were considered to have such extensive disease that they were unrevascularizable. But of the 80% that got revascularized, 76% underwent PCI and 24% underwent CABG. The conservative arm had some crossovers into the invasive treatment strategy. Most of these were due to a suspected or confirmed event of 14% or OMT failure of 4%. In total, about 28% crossed over. It's a bit less than prior studies such as Courage or Berry 2D, but that's the story there. This is the medication use over time. Beta blockers in almost 90% of patients in both arms. Calcium channel blockers in about 35% of patients in both arms. Other anti-anginal medications were used more commonly in the conservative treated patients, and dual antiplatelet therapy was used more commonly, of course, in the invasively treated patients, at least out to about 2 years. This slide shows the primary outcome. Primary outcome was cardiovascular death, MI, hospitalization for unstable angina or hospitalization for heart failure, and resuscitated cardiac arrest. These Kaplan-Meier curves statistically are the same, p-value of 0.34, no difference. A lot has been made out of the fact that these Kaplan-Meier curves cross, with initially the invasive group seeing a little bit more or a little higher event rate, followed by later on the conservative group having a little higher event rate. I'm going to get into that a little bit later, but overall this was a similar, statistically similar result in both the invasive and the conservative arm. Here you see some secondary endpoints, namely death. Both all-cause and cardiovascular death were the same in both groups. No statistical difference. There was analysis, and they they found that only a 10% relative risk, the chance of there being a 10% relative risk reduction by the invasive strategy over the OMT strategy was less than 10%. So very, very similar results, unlikely to be any difference at all in death. Myocardial infarction seemed to be what drove the crossing of the curves, so to speak. Here you can see a little higher chance of myocardial infarction in the invasive arm early on, out to 1 year or so, whereas later on there was a little higher chance of myocardial infarction in the conservative arm. This was driven by the different subgroups of myocardial infarction that were considered. Procedural MI, which was defined by the relatively conservative SCAI definition, requiring at least a 10 times the upper limit of normal increase in MB or a 70 times the upper limit of normal increase in troponin. This occurred more frequently in the invasive arm. As you can see early on, there was 2% excess of procedural MIs in the invasively treated patients. Spontaneous MI, on the other hand, also defined using some standard definitions, but the much more liberal modified third universal definition requiring just some signs and symptoms and a troponin or MB greater than the upper limit of normal. This showed an increase in MIs in the conservative arm over time. It's been reported verbally that there's been no difference in complicated MIs, meaning MIs that were complicated by hemodynamic instability or cardiogenic shock or a drop in EF or electrical instability, but we'll have to wait to see that presented to us also. Here are some additional secondary endpoints. Hospitalization for unstable angina, a little higher in the conservative arm, as you can see. Hospitalization for heart failure, a little higher in the invasive arm. Unexpected result, interesting. No difference in resuscitated cardiac arrest or stroke, both occurring at a relatively low frequency. Now, this is obviously a heterogeneous population in many ways, and so there were some pre-specified subgroups that were pointed out to have a heterogeneity analysis on. Namely, you can see them listed here. There was no difference in any of these subgroups, whether they got invasive or conservative treatment. In particular, no difference whether the patients had 1, 2, or 3 vessel disease, whether they had proximal LAD disease or not, or whether their ischemia was mild, moderate, or severe. There was also no difference no heterogeneity in any of these groups based on age, sex, ethnicity, et cetera. The other co-primary endpoint of this study was quality of life as measured by the Seattle Angina Questionnaire. It's important to note that at baseline, these patients did not have a lot of angina. About a third of them had no angina. The rest either had angina 1, 2, 3 times a month, about 44%, or daily or weekly, about 20%. Here you can see some of the raw data in terms of mean Seattle Angina Questionnaire summary scores. Both groups improved in terms of their Seattle Angina questionnaires, but the invasive arm improved more. And this improvement, or this greater improvement, extended throughout the duration of the study, or as measured out to 4 years. Here's an analysis which shows the benefit that a given individual patient could expect in the invasive arm relative to the conservative arm. In a patient with daily or weekly angina, such patients could almost universally expect some sort of improvement, usually in the range of about 8 SAQ points in the months 3, and then this benefit basically extended out to month 36. Those are patients with daily or weekly angina. This is a patient with no angina. Patients with no angina, as you might imagine, could expect no change in their Seattle Angina Questionnaire score at month 3. Later on, though, there was a little bit of benefit seen at month 12 and month 36 in those who had invasive treatment, perhaps because the conservative treatment developed angina later on. But at the beginning, certainly no benefit from the invasive treatment in the no angina patients. To kind of give this some sort of clinical clarity, because it's not, nobody really knows what SAQ improvement of 8 points means, the investigators gave us an analysis here of angina improvement, or I should say the probability of having no angina based on their baseline angina levels. In the conservative arm, a patient with weekly angina, just placed on medical therapy alone, could expect to have no angina or be angina-free, a 15% chance of that. Whereas a patient treated with revascularization having weekly angina could expect a 45% chance of being angina-free. Trying to give this quality of life metric a clinical foundation. On the other hand, a patient with no angina, whether he's treated with medical therapy or invasively, both of them could expect to have a 90% chance or so of being angina-free. So what are the conclusions? Well, the conclusions, the big, broad conclusions are that initial conservative therapy of stable coronary disease patients with low angina burdens but high ischemia burdens is safe. This basically reaffirms what we've seen in 3 other contemporary trials, all with their limitations. Now, this trial, ISCHEMIA, shows a similar outcome with less limitations in terms of selection bias, showing that the strategy of conservative therapy is safe. Now, there is that caveat of left main disease. I think it's an important caveat. Why is left main disease maybe not part of the results of this study? Well, for one thing, it was excluded from the study. And the reason it was excluded and the reason that these results may not apply is that left main disease does have considerably higher risk associated with it than even 3-vessel disease. This can be seen in the early CABG versus medical therapy studies, which showed that a much larger risk in terms of mortality in the medical therapy arm in the left main disease patients than even the 3-vessel disease patients, even though they may have the same amount of ischemia. The left main itself designates increased risk. And there's also a greater relative benefit to revascularization based on these CABG versus revascularization studies, as seen here in the lower odds ratio of benefit with left main revascularization compared to 3-vessel disease revascularization. So left main disease has greater risk, and then there's also greater benefit in historically from revascularization than any other level of disease. So I think these results really do not apply to left main disease. But this study does extend the results that we saw from COURAGE and Berry 2D and FAME to a broader group of patients who were less selected, who had more ischemia, and who had more anatomical disease than we've ever seen before. This study also tells us that the invasive approach reduces angina and improves quality of life, at least in patients with symptoms. It clearly doesn't do much of that in patients without symptoms, but it does that to some degree in patients with symptoms. Clinically, understanding how much improvement is a little bit of a challenge, but I think those curves showing the chance of being angina-free with one therapy versus the other based on baseline angina are very helpful in that respect of trying to give patients an idea of how much improvement they can expect with revascularization. The one caveat is the ORBITA trial showing us all, when it was published about a year ago, that there is a substantial sham effect to revascularization. This study, if you all don't remember, was about 200 patients who had 1-vessel disease defined as a stenosis greater than 70%. They were all treated with OMT. Then they had a PCI versus a sham PCI and 6-week follow-up after that. Although PCI did reduce ischemia, as demonstrated in improved DSE scores in the PCI arm compared to the sham or the placebo-treated patients, this did not translate into an improvement in symptoms, at least not a measurable improvement in symptoms in the PCI arm relative to the placebo-treated patients. So there's a lot of talk about how much of this effect is we're seeing in the ischemia trial is a sham or a placebo effect, and I don't know the answer to that, and I don't know how we can know the answer to that. One can argue that because the benefit, the reduction in ischemia lasted out to 3 years, that maybe this isn't very important, since it's less likely that a sham effect is going to be so durable, but I think that's hard to know. Some other observations. A reduction in spontaneous MIs were counterbalanced by increased procedural MIs. That was an interesting observation to me, and I thought about it a little bit. I mean, spontaneous MIs being reduced by revascularization, that's been known for some time with CABG, it's actually a relatively new finding when it comes to PCI. FAME-2 is the first study to show us a reduction in spontaneous MIs with PCI. This study with 888 patients, all of whom had coronary disease and FFR of less than 0.8, and were randomized to DES, second generation drug-eluting stents versus OMT, showed no difference in mortality at 5 years, but did show this marginally significant reduction in MIs in the invasively treated patients. And this was pretty exciting. Basically, they did a landmark analysis showing us that this is probably a reduction actually in spontaneous MIs by showing that in the first 7 days, the PCI arm did have more MIs, probably procedural MIs, but afterwards, they had less MIs in the medical therapy arm, not only from 7 days to 3 years, but from 3 years to 5 years. So a continued benefit that kept going out to 5 years in terms of reduction in spontaneous MIs. Again, these results are statistically marginally significant considering the multiple analysis performed, but definitely very hypothesis provoking. And I think, ischemia really supports that concept that PCI can reduce spontaneous MIs. The fact that they were counterbalanced by procedural MIs is controversial. One important fact about procedural MIs is there's many definitions. Second universal definition of MI, third universal definition of MI, the SCI definition of MI, and depending on which definition you use, you get totally different incidence of MIs. Here you can see the 3 definitions used in the same group of 7,600 patients with multivessel disease undergoing PCI or CABG. Really grossly different MI incidences in depending on which definition you use. The other issue with procedural MIs is their prognostic value relative to spontaneous MIs. Completely different mechanism, of course, between procedural MIs and spontaneous MIs. Both of them are MIs in terms of their name, and both of them have myocardial damage associated with them. But because of their different mechanisms, they may mean different things in terms of their prognosis, let alone the clinical context in which they occur. Here you can see a study from the event registry which looked at 4,500 patients with no MI, 500 patients who had procedural MI, and 2,232 patients who had spontaneous MI and had stenting. And you can see the prognosis, you can see the difference in the spontaneous versus procedural MIs. There's considerable difference in the size of the MIs between the spontaneous and procedural MIs, with the spontaneous MIs generally being larger. And you can see also that there was a substantial difference in the mortality that took place going forward, with a substantially higher hazard ratio for mortality in those patients who had a spontaneous MI than compared to those who had a procedural MI. So, the question is, are procedural MIs really less important than spontaneous MIs? I think that question's out there. I don't know how to answer that exactly. I can say that for ischemia, we really need a very detailed MI analysis. What kind of MIs were occurring in our patients? Were they type 1, type 2, the difference in sizes, et cetera? And I think that paper should be forthcoming. And I think the MI difference also leads us to need this long-term follow-up for the ischemia trial. This is something that's being pursued and hopefully going to be funded, but I think 7 or 10-year follow-up on this study will be very helpful to know ultimately whether this difference in MIs has important prognostic implications. The other observation I had was CCTA seemed very useful in patients suspected to have stable coronary disease. First of all, out of the 8,518 patients enrolled with CCS2 angina and moderate ischemia on functional studies, 21% who underwent CCTA had non-obstructive disease. So CCTA got 20% of patients out of having to have a heart catheterization, considering how good the negative predictive value of CCTA is. Another 7.5% had left main disease, also shunting them away from the ischemia or non-invasive strategy, where we don't feel confident that the non-invasive strategy necessarily applies. So CCTA was helpful right off the bat in terms of triaging patients. The second thing is that CCTA, or anatomical disease, was a much better predictor of, or a much better risk stratifier than functional testing. Here you see functional testing, whether the patients had none or mild, moderate, or severe ischemia, their risk in the OMT arm was all about the same. It didn't seem to matter what level of ischemia they had. On the other hand, the amount of anatomical disease the patients had, whether one vessel, two vessel, or three vessel, definitely risk stratified patients into low, medium, and high risk of having events. And this is not the first time this has been shown. It was also shown using the COURAGE data, where 620 COURAGE patients were evaluated based on their amount of ischemia they had and based on how many coronary segments were diseased on coronary angiography. The amount of ischemia they had did not, again, risk stratify the patients, but the amount of coronary artery disease on angiography did. So coronary anatomy seems to be a better predictor of MACE than ischemic burden. And CCTA has been shown to be a pretty effective way to diagnose and treat patients who have suspected stable ischemic heart disease. The PROMISE study, if you all remember, had 10,000 symptomatic patients who were randomly allocated to CCTA or functional testing. Most of the patients who had functional testing got actual imaging. And they were followed for the primary endpoint of death MI, ACS, or procedure complication. The CCTA group did end up getting a little higher chance of having a heart catheterization, probably because of the decreased specificity of CCTA compared to functional testing. Radiation dose was approximately the same, clinically similar, although actually it was a bit statistically less in terms of how much radiation a patient with CCTA would get compared to a patient with a nuclear myocardial perfusion imaging would get. Ultimately, the outcomes were about the same in terms of, were exactly the same in terms of the primary outcome, although I'll say that it was thought-provoking that the death MI outcome may have been a bit less in the CCTA arm. This concept of CCTA maybe actually even improving outcomes was further enhanced by the Scott Hart trial, which actually combined functional testing with CCTA in evaluation of patients for suspected stable ischemic heart disease. In this 4,000 patient study of patients with chest pain who were evaluated by ETT, the patients were randomized to either standard of care treatment after the ETT, whatever the results showed, the patients were treated appropriately, versus actually getting a CCTA and then getting a standard of care treatment with inclusion of the CCTA results in the clinician's database. And 5-year results showed that the CCTA patients were more likely to get on to medical therapy early on at 6 weeks and more likely to be on a medical therapy even at 5 years than the standard of care patients. Really no difference in catheterization or revascularization. And along with that higher chance of medical therapy was a reduction in death in MI or MI by itself in the CCTA treated arm or CCTA evaluated arm. So again, CCTA not only is probably a pretty good diagnostic study, but it may have some added benefits in terms of identifying patients who can benefit from medical therapy. Last, I want to say that the concept of FFRCT, which is really available to us now, in general anyways, I don't know about here at Emory, but is going to enhance, I think, CCTA evaluation of suspected ischemic heart disease patients. This specific trial is an interesting trial which shows us both the advantages and the limitations of a CCTA FFR type evaluation of patients compared to other diagnostic modalities. In this study, 208 patients who had intermediate pretest probability of ischemia were evaluated with 5 different tests: CCTA, PET, SPECT, coronary angiography with 3-vessel FFR, and finally, they had their CCTA data analyzed for FFR CT. And these these patients were then, the predictive capabilities of each of the tests were then compared with the reference standard being angiography with FFR. Some of the caveats: patients who had prior coronary disease, coronary artery disease, atrial fibrillation, and renal failure were excluded. So these patients don't have such good CCTA studies, I can tell you, or have contraindications to CCTA like renal failure patients. The other caveat is even with these exclusion criteria, only about 75% of CCTA tests were fully evaluable. A lot of the problems with the CCTAs were remediable, such as the fact that too many patients had high heart rates, but still there's the possibilities of calcium or other technical problems with CCTA. That being said, when you looked at the accuracy, predictive accuracy of these different tests, these non-invasive tests compared to invasive angiography with FFR, CCTA had the highest area under the curve at 0.94, followed closely by PET, and then computed tomography by itself, just anatomical analysis. So CCTA, FFR had the highest AUC, followed by PET, and then CCTA, with SPECT the lowest predictive accuracy, AUC of 0.70. So I think CCTA is more useful than we probably use it as a profession. I think it should be considered the initial test in many patients, many more patients with suspected coronary disease, although there are limitations of its use. Lastly, I thought was interesting was the suboptimal OMT that was achieved in ischemia, despite the fact of using an OMT protocol and case managers. Here you can see some of the OMT results, baseline versus last visit. Only 66% of patients ended up being on a high-intensity statin. Only 59% of patients actually achieved LDLs less than 70. Only 77% of patients achieved blood pressures less than 140, and that doesn't even take into account our newest guidelines, which suggest 130 systolic is a better goal. This left us with 41% of patients achieving high levels of medical therapy, despite having a protocol and a case managers to push that protocol forward. The concept, I'll just take the concept of lowering LDLs. Only 59% of our patients got to less than 70, and that actually was using ezetimibe pretty heavily. 23% of patients were put on ezetimibe in the ischemia trial. Ezetimibe is a nice adjunctive therapy to lowering LDL cholesterol in patients on statins, which has, and this has been shown to reduce mortality, like in the Improve It study, which looked at ACS patients with ezetimibe plus statin versus statin alone. What wasn't used probably nearly as much, but I think could have a brighter future, is the PCSK9 inhibitors. Alirocumab has been well shown to lower LDLs on top of statins by 50% or more, and along with that, reduce cardiovascular risk. There's really been no defined increase in adverse events, and I think this is probably, we'll find out the data, but I'm pretty sure this was not used very much in our study, ischemia, due to the limitations or logistical limitations. The price has been coming down pretty rapidly from the earlier $15,000 a year to now probably close to $3,000 a year. So I think, you know, it's going to be feasible to use this in more patients, I'm hopeful. The benefit was really seen in these patients here, patients with heavy coronary artery disease burdens, such as patients with prior CABG. Same relative benefit, but because their absolute risk is so much greater, these patients with heavy coronary artery disease burdens had a much greater absolute benefit, and I think could stand to be put on these agents. It's important to note, too, that our guidelines of an LDL less than 70 are being supplanted by more up-to-date guidelines or from different societies like the European Society of Cardiology, where they're suggesting LDLs of less than 55 may be even a better goal in terms of reducing risks in our patients. So what are the implications of ischemia? Well, for me, the concept that highly positive stress test means you have to rush off to the cath lab and get revascularized when you only have stable coronary disease, that's really been debunked by ischemia. It's not an emergency. A highly positive stress test is not an emergency in a stable patient. And I think that ischemia suggests strongly that before you send the patient to cath, a brief trial of guideline-based medical therapy followed by shared decision-making with the patient using the patient-specific parameters is the best approach to patients with stable coronary disease. Does this change the guidelines? This is a diagram or a flow chart that came out of the most recent ACC guidelines on stable coronary disease. I don't think it changes it a lot. Most of these positive stress tests or functional studies funnel into test results suggest high-risk coronary lesions. If yes, you go to coronary revascularization. If no, you go to guideline medical therapy. I think maybe a modification could be, do test results suggest left main disease? If the answer is yes, then maybe you go on to CCTA or invasive coronary angiography for patients whose CCTA is contraindicated. If there is left main disease, then you can go on to revascularization. If there's no left main disease, then again, guideline-directed medical therapy, a brief trial of that, followed by shared decision-making is maybe the better way to go for our patients with stable, low ischemia, or low angina, I should say, but high ischemia coronary artery disease. The other implication, I think, is that CCTA may be a better, a non-invasive test to evaluate patients initially who have suspected stable coronary artery disease. And lastly, I think we're really seeing the limitations of our current system of delivering optimal medical therapy, and I think this is going to require new therapies such as PCSK9 inhibitors being used more, and probably new delivery strategies with more frequent patient visits and or different systems to get patients to be more adherent with the therapies. So in our case, a 62-year-old man questioning the need for cath. This did not really happen to me in the past before ischemia. We talked about it before we did anything. He had no pain since starting medical therapy. He was feeling good and definitely wondered why he was there. We discussed the ischemia results, including the quality of life benefits, the spontaneous MI benefits, as well as the risks of invasive treatment, including procedural MIs. He opted for invasive treatment. He had a PCI of the RCA, which was performed with DES. His LDL that evening, or that next day, I think, was 80 prior to discharge. He'd only been on atorvastatin for 2 weeks. That being said, trying to be more aggressive with medical therapy, we bumped him up to 80 milligrams with the plans to add ezetimibe or switch to rosuvastatin if he didn't achieve LDL goal in another 2 weeks. So in conclusion, I'll say this: ischemia gives us some results, but it is a very large, complex, heterogeneous trial, which is going to require several more analyses and time prior to fully understanding its implications. And I think you're going to see not only the primary results come out in the next month, but you're going to see a lot of sub-studies which are going to help us understand the results better. Thank you very much. Any questions? Yeah.
Kreton, thank you for presenting, I guess, what is now the Super Bowl of OMT versus revascularization trials. So really, you took a nice deeper dive into the study, and I'm curious because you talked about OMT being ACC, protocol driven. Any data about what % of these people were referred to cardiac rehab or participated in cardiac rehab? Because, you know, we know, I mean, the differential here you talk about in, you know, the Seattle Angina Questionnaire, QOL, and we know that comprehensive cardiovascular risk reduction, cardiac rehab improves that along with many of the other metrics here. So was that even tracked? Because it'll be interesting. It may not have been in the, you know, initial presentation, but is there an analysis plan for that? The other questions I would have or comments would be, I mean, your last comments about how we're still flailing with really optimal medical therapy. Even we're not talking about PCSK9 inhibitors and icosapentaenoic acid and you know, on and on and on, SGLT2s, but just blood pressure control, you know, LDLs, and so we do need new care models, and there's a lot of data about PharmDs embedded in care teams, and was the coordinator, quote, you know, coach, what was that person, or any data about differential teams or anything like that? And then last question, just do we need a Orbita CTO trial?
Yeah.
I don't even know if we have a CTO trial, to be honest.
Those are all really, really good questions. So I think question number one, cardiac rehab was not part of the protocol in any sort, part of the ischemia protocol in any sort of meaningful way. It was not like, you know, pushed in terms of get your patient on cardiac rehab by the central ischemia coordinating centers. I don't know if the data was tracked. I suspect it wasn't in terms of what patients ended up cardiac rehab, but what patients didn't. I'm going to put that question forth to the. Yeah, that's a really good point, because I do agree that cardiac rehab could. That would be an interesting sub-analysis if we have that data to see what impact cardiac rehab had, not only on QOL, but maybe also on achievement of OMT goals. You know, one of the questions I have is, you know, is cardiac rehab something that helps achieve OMT goals? I suspect it is, and you know, can that be one of the mechanisms, one of the delivery mechanisms by which we improve our OMT therapy in our society? But I agree, we clearly need better strategies in delivering OMT and achieving our goals. I may have missed a question. I think the last question is there a sham PCI CTO study? And there is. It's ongoing, and it'll be nice to see the results. I don't know how the enrollment is going or how successful it's going to be as a trial, but it's definitely been started, and it's ongoing.
The coordinators, you know, how do you qualify to be a
So,
coordinator or, you know, health coach or whatever?
so the coordinators were trained to be trained in delivering behavioral goals, advice, and counseling the patients in achieving some of the behavioral goals, like eating more fruits and vegetables, reducing smoking risk, reducing smoking. They were not professional counselors. They were research coordinators who were trained in that aspect, and they went by scripts in terms of what they were to tell the patients and in their discussions with the patients. And then they also, those same coordinators helped manage cases in the sense that they followed up on patients' LDLs, blood pressure, brought forth patients who weren't achieving their goals to their primary care or principal investigator physicians, who then were to help achieve those goals. So they were, you know, while not primarily their main job being case management, it was definitely part of their job. And I think it's different. It's definitely was an addition to what we normally have in our clinics, which is really nobody looking after that except the physician by himself. Yeah, Arshad.
Thank you. I just the feed into this study was from ischemia. You had to have ischemia moderate.
Yeah.
But when you look at all the sub-analyses that you were presenting, it seems like almost 15% of the people who had moderate to severe ischemia didn't actually have disease. And
Correct.
Then out of the people who got cathed, 15%, I think, roughly, of who was thought to have CTA disease didn't have disease. So the question is, should we be looking for ischemia when somebody presents? Because we are wedded to this now. The system just, I mean, if you didn't do it, you feel kind of uncomfortable.
Yeah.
But it's almost got 30% wrongness attached to it. Should we be just doing CTAs to exclude left main and then do medical therapy and just revascularize only people who have chest pain continuing? Or how do you think we should sort of modify behavior based on these results?
Well, I think looking for ischemia has diagnostic a value to it above and beyond CCTA in many situations. In other words, sometimes you don't know whether somebody's chest pain or whatever their symptoms are is related to ischemia or not. And to drill down on that, a CTA can't answer that, but a exercise treadmill test might be able to. But what I think should probably be a goal, in my opinion, would be having CCTA as the primary diagnostic strategy with functional testing as a secondary diagnostic strategy in those patients where it's going to seem to add value. That means a lot of patients who get a CCTA would still end up getting functional testing on top of that if it was seemed to add value, if you wanted to know how many minutes a patient could exercise, how much he could stress himself or she could stress himself before she developed ischemia. But I think a primary anatomical strategy may be better in terms of at least risk stratifying patients, and it has a lot of diagnostic value to it. And now we're getting, although it's not a direct measure of ischemia, and really none of them are direct measures of ischemia, none of our tests are, they're all indirect measures of ischemia. Now even CCTA has an indirect measure of ischemia, namely that of FFRCT. So I think FFRCT combined with CCTA is going to take away the need for functional testing in a lot of patients. But a lot of patients can't have CCTA. I mean, you got to have a steady, slow heart rate for a good quality study. You can't have a lot of renal insufficiency. You can't have a lot of calcium or a lot of stents in your heart at this current state of the technology. So there's going to be a major role, I think, for functional testing. It's just that in patients who can undergo anatomical testing, I think it's a little bit better initial strategy with a secondary strategy of functional testing when we think it's clinically useful. Yeah.
So I was going to, one thing that there is a follow-up, so at least there's a follow-up. Orbita 2 is going on now. You mentioned the first one. There's Orbita 2 now is going to be twice the number of people. It's twice the length of follow-up. We'll see. It's still a pretty incremental change, but there's some sort of movement towards trying to understand this better, and they're sort of working from, it's a good example of how you have, when you have an established therapy, you have to work slowly backwards rather than working forwards the way we do other things. One question, well, I had two questions related to the exclusion. So one is, what was the justification? It seems to me that the real problem with this trial is the CTA exclusions, right? And I can't understand the justification for excluding people who had no disease on CTA. That clearly drove the difference in endpoint further out, right? I mean, that favored it towards intervention. And then the second question was, is there any, were there any sort of stigmata on the ischemic evaluation of left main disease? So in other words, were those 465 people, did they have, global ischemia or other kinds of things that could they have been picked out? Right? Those to me seem to be the two big challenges in trying to apply this to a real-world population?
Yeah, so if you stick with your functional imaging first strategy, how do you justify adding a CCTA to everybody to cherry pick these patients? You may say, I don't want to do that, doc. I mean, I don't, why would I want to get two stress tests? Why would I want to get two non-invasive studies when I get one? The justification for adding the CCTA was that they had to get rid of the left mains, otherwise people were not going to enroll in the study. They felt strongly about that. I think once you have that CCTA information, though, to treat a bunch of people for stable ischemic heart disease when they have no coronary disease is tough.
That's what
Yeah, so, right.
Yeah.
Right, but to treat them for atherosclerotic disease may not be appropriate.
It's what you'd be doing in real, like, it's what the real practice would be. If you were gonna drive if you were gonna have a functional test-driven strategy, that group was arbitrarily excluded by a test, and we didn't feel comfortable sending them to CAP. It's like saying, it's like a sham in a sense. You're saying, well, I think this patient probably doesn't clinically need it, but in the trial, we're gonna do it.
So if you stick with the functional study first strategy, then you have to either add CCTA or you have a hard time going with the ischemia strategy. Okay? I mean, I think you can't really, it's tough to apply the ischemia strategy if you don't know anatomy. I mean, I don't really want to treat people with atherosclerosis who don't have it. I don't want to sit there and worry about them. I don't want them to worry about it. So either you're going to have to get a CCTA on those patients, or you're going to have to get an invasive coronary angiography.
I think that the challenge is the whole premise of the trial was to figure out what do we do with these stress tests, with the common strategy being if it's highly positive, you go to CAP.
Yeah.
And then they took off the low risk group,
Right.
which then clearly drives the separation of outcomes later.
Right.
So I mean, I think to me that's the issue, because it sort of, you can say it was it selected for it avoided an unnecessary test. That's true, but it had a different practice flow in a trial that was supposed to test strategy.
Yeah.
I think
I think you're touching on a very important, that whole concept bothered me forever in the study. But actually, now that I know that 20% of my patients who have 20% defect on their, I mean, I've all sort of known that, but now that it's written on a piece of paper, that 20% of patients have a big part of ischemia have no obstructive disease, I want to figure that out. I think it's the right thing to do. And I think for a lot of patients, an additional CCTA is the way to go, rather than a cath. I mean, the difference is 74 out of 10,000 chance of having a complication with cath versus essentially no risk from a CCTA. And, that's an important thing that a patient has to understand. But that can be part of the shared decision-making process.
Is that group being followed up?
The patients who did,
CCTA, but
they're
were
not
excluded?
they're not having longitudinal follow-up, although we have their initial data on it. Yeah.
Just a quick question, following up with that, for the basic inclusion criteria, I don't know what, I want to see your take on that. How many patients that had a negative stress test ended up having a CAT and ended up having significant lesions that actually were causing trouble?
You mean how many patients who had a negative CCTA?
And I'm talking about people who didn't, not in this study, but
Ah.
generally in practice. I've had a few that had a negative stress test, completely clean, ended up getting a CAT, just like burden of symptoms. 2 months later, had significant disease that was fixed, and afterwards they felt significantly better. There's maybe placebo effect, we know all of that, but that group was never included in that trial.
Right, that group was not included in this trial, and I know that that happens not infrequently. And I actually think that's probably why CCTA has a little bit better outcomes associated with it than functional testing, because it doesn't miss that group with at least in the case of myocardial perfusion imaging, of patients with quote-unquote balanced ischemia many times, or false negative stress tests for whatever reason. Yeah.
It looks balanced on the
Yeah.
myocardial perfusion imaging, but at the same time, it could be revascular disease.
Right.
That needs to
That's one reason that happens. So I think that's why CCTA, probably a more sensitive test for atherosclerosis, is a valuable strategy.
So it's hard to know what to do nowadays. We always struggle with defining what stable and unstable angina is. You know, what is stable angina? How long has it been going on? Do you have patients in your clinic have stable angina? You know, every time I have somebody tell me they took nitroglycerin, it kind of causes my blood pressure to go up. So then you also have to take into account your CTAs. And, you know, what is the availability? Who's reading them? Where do you have to go to review them? Are you really in it or not? So it's hard to talk about recommending that if you don't deal with that modality right in your backyard.
So I agree with you. Logistically, CCTA is very difficult in our system at the VA, and I suspect it may be difficult here, for all the reasons that you just said. Just to give you an example, I can get a cath tomorrow or next week at the VA. It's going to take me 2 months to get a CCTA at the VA. That's an example of a non-fee-for-service place. I don't know what hiccups you have here, but the reader's incredibly important. I think reading is something that can vary greatly, and I think that needs to be in the hands of people who are clinically familiar with atherosclerotic coronary disease, i.e. people who know coronary angiography, people who know what happens with patients. When you get that going on, when the cardiologists who know the patients and know about coronary disease are reading these studies, you're going to have a better field. And then we got to develop the infrastructure. You need to have the scanners, and they need to be easily and ready to use. And I think there's a lot of good points there. It's not necessarily ready for prime time, but it is something that we should think about moving towards. Thank you. Thank you very much.
The preceding program is copyrighted by Emory University.